Good.
Very good evening. A very good evening to all the
Very good
respected
evening.
dignitaries, guests, colleagues, and dear delegates. I, Dr. Preeti Bhardwaj, Professor and Head Department of Orthodontics at Mansarovar Dental College, Bhopal, and Organizing Secretary of this program on behalf of Mansarovar Dental College and Central Zone of ICD Section 6, would like to extend a warm and hearty welcome to all of you. A warm welcome to our Chief Panelist, Professor Dr. Jyotendra Kumar Sir, former Joint Director of Medical Education, Government of Kerala, Padma Shri Professor Dr. Mahesh Verma Sir, President ICD Section 6 Dr. R.P. Gupta Sir, Organizing Chairperson Professor Dr. D.N. Kapoor Sir, our panelist Professor Dr. Pradeep Raghav Sir, Secretary General ICD Dr. Rajiv Sir and ICD team, Deputy Regent Professor Dr. V.S. Kohli Sir, uh, Deputy Regent of Central Zone ICD Section 6, board members of ICDs, fellows of ICDs, colleagues, and dear delegates. I welcome you all to this webinar on the Forsus Appliance Predictable Class 2 Correction Independent of Patient Compliance by Dr. Ramesh Sabloksa from Dubai. This webinar is jointly organized by Mansarovar Dental College, Bhopal, and the Central Zone of ICD Section 6. This webinar is possible because of the support and encouragement of respected Mrs. Manjula Tiwari ma'am, Chancellor Mansarovar Global University, respected Professor Dr. Arun Pandey sir, Vice Chancellor Mansarovar Global University, respected Shri Gaurav Tiwari sir, Chief Executive Director and Pro Chancellor Mansarovar Global University, Bhopal. Without their support and guidance, this program would not have been possible. Our mentor and organizing chairperson, Professor Dr. D.N. Kapoor sir, has played an instrumental role in organizing this webinar, and without his efforts, this program would not have been possible. Our dynamic dean, Professor Dr. Gurdat Naik sir, has played a key role and has been instrumental in organizing this webinar. After the presentation, we will have panel discussion and question and answer session. We are honored to have with us Professor Dr. Jyotendra Kumar Sir as the Chief Panelist, Retired Joint Director, Medical Education, Government of Kerala, past President IOS, past Chairman Indian Board of Orthodontics, past President Indian Society of Dental Research, is been honored with the Best Doctor Award by the Government of Kerala, Best Researcher Award, and many more awards to his credit. There is also the PhD guide and examiner to most universities in India. Keynote speaker at various conferences, served as the executive member of the Dental Council of India. We are honored to have also with us a panelist, Dr. Pradeep Raghav sir. Dr. Pradeep Raghav sir is the head of the Department of Orthodontics and Dentofacial Orthopedics at Subharti Dental College, and also the Dean of Students of Welfare at Subharti Swami Vivekanand University. Dr. Pradeep Raghav sir is the editor-in-chief of JCU iOS, past editor of iOS Times News and Letter, and has conducted various hands-on courses and has been keynote speaker in various conferences and CD programs. Sir has published various articles in national and international journals and has published various books. Sir has been the EC member of iOS for the last eight years. There is also an inspector of DCI in various universities and colleagues. We have with us our speaker, Dr. Ramesh Sablok sir. May I take the opportunity to introduce him? He has completed his master's in orthodontics from Louisiana State University, USA, has fellowship from the Royal College of Surgeons and Physicians of Edinburgh and Glasgow, diplomat of Royal College of Surgeons, and he has certified specialization in lingual orthodontics, Invisalign, growth modification with functional appliances. He is a recipient of various honors, awards, and scholarships. He has a professional experience of about 40 years in both clinical and academic aspects. He is currently a consultant orthodontist in UAE. He has numerous publications to his credit and has conducted more than 150 workshops and courses on various aspects in orthodontics. Recently published chapters in the book on the functional appliance by Dr. William Clark. So may I now take the opportunity to invite Dr. Ramesh Tablok sir to kindly share his knowledge through his presentation.
Thank you. Can you hear me now? Hello?
Yes, sir. Yes, sir.
So it's a great honor and privilege for me to speak for the International College of Dentists. Thanks to Dr. Preeti Bhardwaj for the introduction and all the members of the ICT and the Mansarovar College for this invitation. Thank you so much. So today we are going to talk something about the Forsus appliance, class 2 correction independent of patient compliance. So when we talk about the functional appliances, there are various options. We have removable appliances like bionators, activators, or twin block or Frankel appliance, or in the category of the fixed functional appliances, we have interarch appliances like pulling type, we use a class 2 elastics, or we have like something like safe springs. In the pushing type, we have Hubst appliance, Jasper jumper, which is a soft version, and the Forsus springs, which we are going to talk today in detail. So if you see, there are so many options in the fixed functional appliances. You have, for many years, we have been using the Hubst appliance, which used to be very rigid, either a bonded Hubst or a bended Hubst, or we use something for Omnicore like a bite fixer, twin force, Jasper jumper from American Orthodontics, Subaga, and so many other appliances. So all these appliances, basically, they are similar in nature. Most produce the same vectors of force. All are independent of the patient cooperation. So independent of the patient cooperation. So what it does is it moves the upper maxillary dentition distally or backward, and the mandibular arch and the mandible forward. This is the basic function of all the fixed functional appliances. So basically, the treatment affects the fixed class 2 correction appliances, Forsus appliance. It is similar to any other fixed appliances in class 2 correction. It has got advantages of efficiency and predictability, and it is very easy to insert. You don't need a lab procedure like you use for the Hubst appliances, and it is very easy, very quick to master. In a couple of 5 to 10 minutes, you can fix the appliance, and excellent patient acceptance. And now, after 20 years of the invention of the Forsus appliance, there are variable force factors depending upon the attachment techniques. Like you can have, if you have got an open bite case, you can have a more vertical vectors. If you have got a deep bite case, you can have more horizontal factors. So you can manipulate depending upon the kind of malocclusion. And then there are multiple applications other than the class 2. You can use it as a distalization appliance. You can use it for the midline corrections. So there are so many other uses other than the class 2 corrections. So what are the force factors associated with the Forsus appliance? So the forces in the Forsus appliances, it works in a posterior direction in the maxillary arch. It is more horizontal and intrusive. So the upper arch get more intruded. And in the mandibular, the forces are interiorwards, which is horizontal and intrusive factors. So this is how the force systems works with the, but also the Forsus appliance works in a transverse direction, is more expensive in nature. So there are two versions of the Forsus appliance. One is Alpine type, another is the EZ2 modules. So we will discuss both of them together. It is not only in anterior posterior direction, but it also expands your upper arch. So what are the force factors with the class 2 elastics? Class 2 elastics, basically, they are working more, they are interior in nature, they're horizontal and extrusive. It extrudes your upper teeth. And in the mandible, it also extrudes your posterior teeth, leading to the downward and backward rotation of the mandible, which is not a good thing for class 2 correction. Actually, it makes the class 2 more worse. So when we compare with the class 2 elastic with the Forsus appliance, it is the class 2 elastics, they are more extrusive in nature. It leads to more bite deepening, whereas the Forsus appliance works the maxillary arch is more intrusive and posteriorward, whereas in the lower mandible, it is more forward and intrusive, which is a good thing. It is in terms of the direction of the facial growth. So these are the pulling forces for the class 2 elastics is undesirable. It leads to rotating the mandible downward and backward, whereas in the case of the Forsus appliance, it is more intrusive and it has got beneficial because it doesn't extrude your posterior teeth, and there is more closer of the mandibular plane rather than downward and backward movement, which you get in class 2 elastics. It is just more than a substitute for class 2 elastics. Forsus appliance, there are multiple applications other than the class 2 corrections. As I explained to you, you can correct open bites, you can correct the deep bites, you can correct the asymmetries of the face, you can correct the midline. So there are many various ways. The only thing is that where there is a variable force factors depending upon the attachment technique, which we will discuss in detail, how you are going to place the appliance and able to modify and activate after initial placement. So let's see this. Like this is a patient with an open bite. Here there is a patient on the right side. There is a maxillary protrusion, and also down below there is a patient which has got a deep bite. So all the three different kind of malocclusions can be treated with the Forsus appliance. The only thing is there's a different vectors of force which we have to adjust, and we will discuss that in detail. This is the open bite case which we have corrected in the post-treatment. This is the maxillary protrusion case, and this is the deep bite case. So how we are going to treat, I'm going to discuss with you. So now let's talk something basics about the basic components of the appliance. So basically you need an occlusal tube in the first upper maxillary bands. We use that, and then we have got the coaxial spring assembly which we use for the which we fix it on the occlusal tube. So there are two options. Either you can use an L pin or you can use an AZ module. So there are two options. One is a EZ module, another is the L pin, and then you can these days we also can have a wire-mounted version of the tube, which you can put on your wire even if you don't have a band, and you can fix it. And then we have got push rods of different sizes from 22 to 38, depending upon how much activation we want. And this is the ruler which we use to select the rods. And then in the lower wire is always the rigid wire, either 019-025 stainless steel or 019-025 beta titanium. So these are rigid wires in the lower, and then we use the elastomeric guards on the premolar, on the canine bracket, just to act as a buffer so that the bracket should not break. And then we use the spacers to activate the appliance. So what are the components for the Forsus appliance? So we basically should using the MBT system with O2 slot. And in the lower interiors, we must use either -6 degree or -14 degree torque, -6 degree torque in the mandibular incisors, and -14 degree torque in the maxillary buccal tubes to prevent the rolling. One of the side effects of all fixed functional appliances is the protrusion of the lower interiors. For that, we have to use a -6 degree torque, that is the labial root torque in the lower interiors to prevent the flaring of the lower interiors. Then the mandibular arch should be either 0215, 025 or 019-025 stainless steel wire or beta titanium wire in O2 slot. And mandibular arch wire should be always cinched at terminal molars. And then we use the elastomeric module with guard placed on the lower cuspid or bicuspid bracket, just facing distally, acting as a bumper or a cushion so that the bracket should not fall. And then we have got a steel ligature tie at cuspid or bicuspid bracket. In the maxilla, the arch wire varies with the case. You know, when I started using the Forsus appliance in 2001, we used to have stainless steel wires in maxilla and mandible, almost full-size wires. And then we used to use TPA and the lingual arch. No, those things are not possible. Things have changed. The thinking have changed. Only the lower wire is always the rigid wire. Though we have got two modules options module, either you can use a EZ2 module or the L-pin module. The push rod, which activates the spring assembly, comes in 6 different sizes, and you have to select the appropriate size of the rods depending upon the distance from the distal of the upper buccal, the occlusal tube, to the exact position where you want to place the either distal to the canine or the first bicuspid or any stop. And sometimes the TPA, the transpalatal arch, is optional to prevent the buccal rolling of the molars. So these are the 2 options available for the Forsus appliance. You have got a EZ2 module, which is, or you have got a L-pin type of this options available. So EZ module, we will discuss these one by one. So this is the spring which goes into the headgear tube. It snaps into the headgear tube. And then after you put this, you can put the rods, which is either distal to the canine or the premolar. And this is how this appliance works. This is the 3-piece telescopic spring designed to allow for enhanced patient jaw opening. And these are anti-rotational arms. So the Forsus spring and the rod create an equal and opposite force to the maxillary dentition and the mandibular dentition. So the fully activated spring exerts approximately 200 grams of force on the maxilla and mandible. In the maxilla, it works in the distal force, and in the mandible, it is a mesial force. That is how the class 2 is corrected. So what is the treatment protocol or guidelines for installing the Forsus appliance? Number 1 is we must coordinate the transverse dimension before installing the appliance. That means what I teach in my postgraduate students, you take your models, move your lower jaw forward and see the relationship of the transverse. If your upper arch is constricted, less than 30 mm, better go for the rapid palatal expansion. Or you can, if it is a minor, we can still expand with the Forsus appliance, and you have to use a light wire at the top. Additional splinting with the arch wire, lower arch from terminal molar on the right side to the contralateral side with the ligature wire. Then we use the elastomeric ligature modules with guard or Guerrin lock distal to the mandibular first bicuspid or cuspid, so that when the rod touches the bracket, or the bracket should not break, so it is just acting as a buffer or a cushion. The mandibular arch should be always a rigid arch, either 019, 025 or 021, 025 stainless steel or beta titanium, and in 022 slot, and it should cinch back the arch wire at terminal molar. Consider placing the arch wire at an appointment prior to the placing the Forsus springs. And mandibular MBT system, it should have -6 or -10 degree labial root torque brackets, and also place additional labial root torque if is already a flaring, if the lower interiors, to prevent the lower interior flaring. Place transparental arch in the upper. It is an optional if you want to keep it. So select the appropriate size of the push rod with the patient closing in the centric occlusion, and place the clip of EZ2 module or L-pin in the maxillary occlusal tube. Insert distal portion of the push rod into the spring module and place mesial portion of the push rod behind the mandibular first bicuspid or cuspid, and crimp the loop of the push rod after checking the activation. Maxillary arch varied with the treatment objective. You want a soft wire or a flexible wire, or you want a hard wire, depending upon what is our aim. Forsus remains in place until ideal overjet and overjet is relationship and class 1 molars are obtained. So what is the standard setup? The standard setup is
Volume. Your volume, you're not audible.
He has muted himself, sir. Dr. Ramesh, please unmute yourself. It's showing a mute signal.
You have to unmute.
The mic is showing.
Dr. Sablok, sir, kindly unmute yourself.
Unmute.
Yeah.
Yeah.
Yes, sir,
Yeah.
you're audible.
Now you're audible.
Again, you have muted you.
Sir,
Dr.
kindly
Sablok,
unmute
please
yourself.
yourself. You're still, that's better.
Can you hear me now?
Yes,
Yes.
sir. Yes, sir.
Yes.
Please go ahead, sir.
So one of the most important thing is cinching, which people make mistakes quite a bit. The cinching should be very close to the buccal tube. And what I suggest is you take a mosquito forceps or a Weingart plier, put it on the distal and the mesial of the buccal tube and cinch it very nicely, as close as possible. This is one of the ways to control the incisor movement. Because, and also ligature wire through and through from the molar to molar is very, very important. And we should cinch the arch wires distally. Another thing is, other than the cushion, you have the option of using a Guerrin lock distal to the canine or to the premolar, wherever you are going to place your rod to prevent it. Just very simple steps. Take a ruler which comes along with the appliance from the distal of the occlusal tube to the point where you want to place the spring. These days, the ideal location is distal to the first premolar. See what size you are getting. If you are getting 22, go for 22 size. If you are getting 25, you go for the 25 size of the rod. So if your point is in between two brackets, always select the smaller size. Less activation is better than overactivation. Overactivation leads to a lot of problems like flaring of the incisors, rolling of the molars. So you have to select the size. Then you put with a Weingart plier the EZ module from the into the occlusal headgear tube, and then you put the rod which you have selected on the lower arch wire distal to the canine or the first premolar, and then the distal portion of the rod goes into the spring, and then you crimp this this rod. This was for EZ module. For L-pin, the L-pin which comes with the packet, it is very long. You should always cut a little bit, but keep 2 millimeter distal to the tube to bend it either buccally or vertically. Very important, because when you keep it more buccally, your spring can come more outside. Sometimes there's an interference. You can adjust that. So either vertically or buccally, you should bend it. So 2 millimeter distal to the tube, bend it, and then we put this the rod onto the canine or the premolar, wherever you want. Are you hearing me? Can you?
Yeah, we are.
Yes,
You are,
sir.
fine. You are doing very well. No
Okay.
problem.
So what are the case selections? What kind of cases we see with the Forsus appliance? You can have a deep bite or open bite class 2 cases. You can use it as a molar distalization appliance, maxillary distalization. You can use it for maxillary asymmetries. We can use for mandibular asymmetries. You can use maxillary encouraged in extraction cases. You can use encouraged for mandibular incisor in extraction cases and early intervention in severe class 2 cases. So I'm going to show you case by case all these varieties, 1, 1, 2, 2 cases, so that you understand better. Now, some of the very important points for any fixed functional appliance is controlling force factors associated with the appliance. How we are going to do. What I used to use Forsus appliance in 2001 and what I am using today is a huge difference, because we have been better informed. Now we have to see what is our purpose, goal. The location of the attachment of the spring. You want more horizontal or you want more vertical? If it is an open bite case, we will have more vertical, more intrusion of the upper posterior segment. You have got a deep bite case, more horizontal. The wire, the lower wire is always stiff, can be a beta titanium or a stainless steel, but the upper wire, you can have a nickel titanium if you want expansion. If you want to have like a gummy smile, you want to intrude the upper interiors, you can have it with a wire, with a nitinol wire with a reverse curve. So you can select the wire depending upon the case selection. We will show you the cases so that you can understand better. Now, these are the spring attachment options to optimize force factors. Now, if you are wanting a more horizontal movement, like you have got a deep bite case, you want to intrude the interiors, then you use the occlusion tube with the EZ2 attachments, more horizontal component. You want to have more vertical component, then you use the L-pin, and you can either use L-pin from the occlusal tube, or you can use from the gingival tubes. You can have on the gingival tubes. So if you need more vertical, you can use the from the gingival tube, and you're sorry, go back. Sorry. So you can have you can use the L-pin depending upon the what exactly you want. You want open bite cases, so more vertical position of the spring. You want deep bite cases, more horizontal component of the spring. So the direction of the spring is extremely important when you treat these patients. But let's talk about where you should put the push rods. If you are having a patient with a deep bite case, so you should initially start with the cuspid, but the best option today is the first bicuspid, because it leads to the less flaring of the lower anteriors. But if you have a case where there's a very deep bite, you can start with the canine, and then you can change over to the first bicuspid, depending on how the occlusion changes. Occlusion changes from class 2 to class 1, so you can change the direction of the placement of the push rod depending upon the need. And the other option is you can have like a omega loop. You can that is another option. And the third option is the crimp hooks. In that way, you have to remove one bracket, and this is so most commonly which we use is either cuspid or bicuspids. If we are putting on first bicuspid, the length of this rod is normally 22 to 25. If you are using on cuspid, most 9 to 32. So you can change it the way you want. My preference is first bicuspid installation, insert rod distal to the mandibular, first bicuspid. Usually it is 22 or 25. Never use over-activated rods. Under mild force, light forces are better than over-activated. Whenever you use an over-activation, you will end up in big problems. What is the profile difference? So when we have got a first bicuspid, the profile difference with the rod location, first bicuspid closer to the dentition in line with the buccal segment, and when we on the cuspid, there's less rotation of the sporting tooth. You can see the protuberance. The patients like the first bicuspid, you don't find anything on the buccal side or any kind of a swelling or this thing like this. Let's have a look on one patient. She is 15 years, 6 months old. She has got a crowding, constricted arch, and convex profile. So in this case, if you see, this is the initial ceph, and the A and B is around 7.4 degree, and she has got the FMA around 29 degrees. So it's a high angle case. So we chose to put it distal to the first premolar. Forces attached to the position in the maximum to maximize the vertical control of the posterior maxilla. Always remember, when you have got high vertical cases, please always select distal the vertical position, either with L-pin or this thing. If you have got a deep bite cases, always go for the EZ module distal to the canine to start with. And this is just after the forces, we brought the lower jaw forward around 7 millimeters. And if you see it here, the A and B is 4.6, and the FMA is reduced 24 degree, which was 29 degree before. It is because of the intrusive action of the Forsus appliance, because it is working in a vertical direction. And this is the final ceph. If you see it, I'm not going into detail in very much, but I want to teach many things together. And IMPA, which is one of the shortcomings of all fixed term functional appliances, is 94.3. It stays like this because we have cinched nicely, we are doing cinching, we are doing all preventive measures to prevent the lower anterior flaring. Always remember one thing, when you are flaring the lower anteriors, you cannot have mandibular projection. So you will not have good profile because you cannot correct the posterior occlusion. So your main aim is see how the profile has improved. The lower jaw comes forward and nice occlusion. This is why, because we chose to put the the rod distal to the first premolar. Very important. So force has to be 200 gram. Don't overactivate. That is very, very important. Let's talk about controlling mandibular incisors, which is the most important component in fixed functional appliances. How we can do it? All side effects of all fixed functional appliances is the lower anterior flaring. Excessive flaring can adversely affect the post-treatment stability. Excessive flaring inhibits ability to correct the buccal segment to the class 1 position. So what we should do? Proper activation of the appliance. Number 1, cinching of the mandibular arch securely against the mandibular molars. Cinching should be very nice. Just don't do it with the Weingart pliers. You have to do at 90-degree cinching so that there is no play between the wire and the tube. Placement of the mandibular push rod against the first bicuspid, which I always told it is better because you have got more teeth to prevent the flaring. And use of negative torque brackets on the mandibular incisors, either -6 or -10 degree. So activation. When we activate, the spring is fully, when the patient closes the mouth, the spring is active. So when the spring is active, there should be 2 millimeter of space between the stop and the spring. That means it is an ideal activation. If there is no space, it is overactivated. So this is, and patient should close in centric correlation. That's how you will check the activation. So how we select the rod? This is the ruler which comes along with the appliance. Hold it from the distal of the occlusal tube to the tooth where you want to put, whether canine or premolar, in centric correlation. And this is like most of the time an ideal position. Distal to the canine is 32 millimeter rod. Distal to the premolar is 22 millimeter rod. And to achieve the correct activation, you have to select the correct size of the rod. If you will use a bigger rod, more activation, more problems. So this is rod size selected patient in centric occlusion. So it gives you 200 grams of force when the Forsus spring is compressed. So checking the activation. Check prior to crimping the rod. Don't crimp the end of the push rod until you check that your activation is correct. Correctly installed appliance exerts force around 200 grams of force. If you overactivate, it can lead to the debonding of the mandibular brackets, flaring of the mandibular incisors, rotation and rolling of the maxillary molars, opening of the bite. So these are the side effects. If the end of the push rod comes out of this spring, that means it is overactivated. It should be like this. Thus, the end of the rod should not come outside the spring. This is another point. Now, if you are overactivating, like this is here, there is an overactivation. Your spring is buccally placed, the buccally rolled out, will roll out to the buccal side. So it should not be like this. You should not overactivate it. The correct activation of the alpine, this is like this. Similarly, the correct activation of the EZ module is like this. In overactivation, it goes buccally. So don't let it happen if it is overactivated. So if you find a space between the stop and the spring, it means it is inactive. You have to activate it. You can use the spacers. It comes along with that. One spacer gives you 2 millimeter of activation, so you can activate it. One crimpable stop at every 6 to 8 weeks in growing patients, you can activate it. One crimpable stop at 10 to 12 weeks in non-growing patients. After 2 activations, need to change the rod size. Most patients only require 2 activations, maybe unilateral or bilateral. So you can put a crimpable stop just distal to the stop and just crimp it. So one small, this one crimpable stop gives you 2 millimeter of activation. So this is how we activate. And don't call the patient too early, not less than 6 to 8 weeks. Cinching, like this is not good enough. This is the correct way of cinching. It's very, very important. So what are the advantages of the first bicuspid installation? Is most favorable force factor when considering the entire mandibular arch as one unit. One first bicuspid location places force closer to the center of rotation of the mandibular dentition. The center of resistance of the entire mandibular arch to control lower incisor flaring. So first bicuspid installation is always better. Now, why use negative torque brackets for the incisor control? The negative torque in the incisor bracket moves roots labially and crowns lingually. So, but when forces is used, forces push the rod rod tries to tip the crown labally, and so this nullifies the effect. This is why we use -6 or -10 degree. So the forces moves the crown forward, whereas the negative torque moves the negative torque moves the roots labally. So this nullifies the effect. So that's why you should use -6 to -10 degree torque brackets in the lower interiors. This is very important. Negative torque in the incisor brackets moves roots labally and crowns lingually. Forces push rod tries to tip the crown labally and root lingually. Let's see one case. This is 11-year, 4 months patient. She has got a mild class 2 dental relationship, modern overjet, maxillary dental diastema, deep bite, retrognathic. And we used first bicuspid placement. This is the profile, mild retrognathic. And if you see, the FMA is 19.8 and ANB is 5.7 degree, and IMPA, which is the most important thing for which I'm showing this patient, is 104 degree. So this is after 5 months of the forces, and see the inclination, the IMPA, which is 103 degree. Why? We put the rod distal to the first bicuspid, and if you see the relationship, the starting IMPA is 104, and this is then 103, because we put the rod distal to the first bicuspid, we cinched, and we also did splinting of the lower arch. This is very rod placed at first bicuspid, lower incisors slightly upright. If your incisors are upright, you can have better mandibular projection. You can bring the lower jaw forward. But if your lower incisors already flared, start touching the upper interiors, you cannot correct the skeletal effect. Very important point, very, very important. This is 1 year retention after this, and this is the after 1 year of CEF. And this is, if you see it very carefully, this is the how the profile has improved. This is, see the chin, how it has moved forward. And this is initial, final, and post retention. So this is, I'm going to put it here. So this is 1 year retention. So this is initial, final, and 1 year, 7 months. And this is after 20 years old now. 7 years post retention, the results are stable. This is only happening when you are taking all these precautions, not overactivation, put the rod just distal to the first bicuspid. Let's talk about the next step, which is the treatment timing to optimize treatment response. Last time I discussed in detail about the CVM method, cervical vertebra maturation method. So the timing, we should time for the fixed functional appliances with the peak of the pubertal growth spurt. It means CS3 or CS4, which we already discussed last time in detail, the CVM method. This is the stage which we should start with the fixed functional appliances, ideal. But now, because the teenagers, they are not compliant, they don't use removable appliances. Even I have been treating patients of 14, 15, 16, 17, 18, 19 with functional, it works. But the more you go higher age, is more of a dental effect than the skeletal effect. You will see the changes. This was my first case of Forsus appliance. So we do all mistakes and we learn with our mistakes. So I'm just sharing with you. It came out very nice, but what I've learned over the years, I'm just showing you. This was Omar, retrusive mandible, deep mentolabial sulcus, convex profile. And this was the very constricted upper jaw, lower interior crowding, full class 2. If you see the models, this was the profile, deep mentolabial sulcus, retrognathic mandible. These are the classical cases which should benefit from the fixed functional appliances. At that time, the child was 13 years of age. So what was the summary? It was class 2 case, increase in overjet, maxillary transverse deficiency, retrognathic mandible, deep bite, maxillary protrusion. What is the plan? So when you have got such constricted upper jaw, constricted arch, always think of rapid palatal expansion first. And the test for that is keep your models in your hand. Move your lower models forward. You will find when you move your lower models forward, you will find constricted. You are going a wider part of the lower arch moving forward against the constricted parts of the upper. It means you need expansion. So the best way is to go for an expansion for 1 month, 6 weeks period of retention, and then go for the fixed functional appliances. This was full unit class 2 case, both the sides. So here this kind of patients, so that's what I'm going to teach here. The lower incisors are flared, hell of a lot. So these kind of cases, these days, today, if I have to do, I might have to do with them 2 microimplants between 4 and 5 to hold the incisors, so that when I move the lower jaw forward, I also use microimplants along with the Forsus appliance. This is when I started, I used with the rapid palatal expander, level the lower arch. This was 12 years, 6 months. This is the day I put the fixed functional appliance. This was my first case, learning curve. After that, I worked with Lisa, the lady who invented this appliance, also with 3M people, and we became much, much better informed. Those days, we used to use transpalatal arch, lingual arch, sturdiest wires, rigid wires in the upper and lower. You only need a rigid wire in the lower, not in the upper. So these things have changed. So this was placement of the Forsus appliance. This was with L-pin design, which I used it. I brought it forward. You have to bring the lower jaw edge to edge, always overcorrect by 30% because there is always a relapse. So this is just post Forsus, and after the appliances were removed, and this is the profile after 1 year of the treatment. So it has improved a lot, but the lower incisors are flared, and after you remove the Forsus appliance, there is always the lower incisors rebound back 2 to 3 degrees. It goes back in our experience. So that helps you, but you can get better skeletal corrections if you control your lower incisors from day 1, because basically we need mandibular projections. This is after 1 year. The progress, this is the post-treatment, nice results, but then this is the occlusion, very nice occlusion, midlines are on, canine relationship class 1. But if you see the post-treatment study models, pre and post study models, and then when I see this X-ray and when I see this lateral ceph, your incisors are flared. So this, you have to take it from day 1. You might have to remove your 3rd molars and go for 2 microimplants, push your lower interiors backward, and then you get a better projection. But I think I got a reasonably good results with this patient. I finished within 2.5 years because we did expansion also in this case, rapid palatal expansion. So whenever we do an extra procedure, this was before and this is after. So this thing which I never liked. So when I published this case in the book with Dr. Clark, so he made a remark in this, how the fixed functional appliances lead to the flaring of the lower interiors. And this happens in almost most of the cases unless you take it. This is another, my colleague's doctor. He's a consultant cardiologist, his daughter. So this was Alicia, severe class 2, both the sides. So, and also you will be surprised to know, we put a software with Bill Arnett where we have found out the airway space, how when you bring the lower jaw forward, the volume of the airway space increases almost double. So this was, those days, these were my initial cases. We used to put lingual arch, we used to put a TPA, and then we used to measure this and then put the Forsus appliance. This is what I'm talking about, the cushion, the elastomeric guard, which we put distal to the bracket so that the bracket doesn't break when the spring of the force is there. And this is the 12 years, 9 months. This is closer to the finishing. And this we remove the post Forsus appliance. And in this case, I had to distalize the upper segment little back. And this is 14 years, 7 months. This is the finished product. So when I analyze my ceph, you find a little bit of flaring in the lower interiors. But as long as you get a good profile, most important thing, your chin and profile should be much better. That is very, very important. So this was before and this is after. It almost took 2.5 years. And this is the occlusal views, ceph, pre-treatment and post-treatment. And this is the OPGs. And see how the profile has improved between the pre and the post. This is a nice case. This is a learning case. This patient came at 15 years, 3 months. So I told her that I will try for you, but no guarantee, because when the growth period is over, you get more of the dental effects rather than the skeletal effects. But fortunately, this worked. Very severe crowding, 2-unit class 2, both sides, and upper arch is constricted. So I started with the rapid pelt. This was the profile to start with. So I started with the rapid peltal expander first to start. She was 15 years, 3 months old. And then I put the fixed functional, the Forsus appliance to move it forward. And this was EZ module. And this was after the Forsus appliance were removed. And this is how the incisors are there. And this is the closer to the finishing. And this is the post-treatment. So when you have patients like this, 15 years, 16 years, 17 years, these appliances still work. But then you have to take into it, there's more of a dental effects rather than the skeletal effects. Are you listening? Are you hearing? Hello?
Yes, sir.
Are you?
Yes, sir. You're audible, sir.
Okay, thank you. So this is the post-treatment case, and this is the pre and the post, how the profile has improved. 15 years, 3 months, 17 years, 10 months, and how the smile has improved. This is the intraoral occlusal views, pre-treatment and post-treatment. And this is the occlusal views. This is the profile, how it is improved. We brought the lower jaw forward. This is the lateral ceph and OPG. So what we should look at each appointment when patient comes. This is a very important slide. When patient comes back to us, we should check the activation in the centric occlusion 6 to 8 weeks interval, whether your spring is active or passive. If it is passive, you activate it. Evaluate maxillary incisor torque. You always see that you don't lose your upper torque. Very important. Evaluate mandibular incisor proclinations. If they are protruding, you have to find out the reason why they are protruding. If the maxillary archway is not cinched distal to the molars, distalization cases, you have to leave the wire straight. You leave little extra wire so when you can push the molars back. So there's an adequate amount of wire at the back of the buccal tube. Check that the spring modules are not interfering with your occlusion. This is very important. When you overactivate, your spring will interfere with the brackets and that will destroy everything. Check wire engagements in all brackets and check that the cuspids and bicuspid, depending upon the patient, your ligature ties are intact. And once the desired amount of activation is achieved, it is recommended to keep the non-activated appliance at least for 1 appointment. After you have achieved class 1, leave it for 6 to 8 weeks in the passive position. That will help you. So the duration of the treatment on average Forsus appliance works around 4 to 6 months for class 2 correction, except unilateral midline correction or used as an encourage, and disengages to check the occlusion, leaving passively for 8 weeks. Slight overcorrection is very important. And this is what is required. Very slight overcorrection, 1 to 2 millimeters. Overjet eliminated. Class 1 molar, slight overcorrection is important. Class 1 buccal segment or slightly overcorrection. Ideal torque in the maxillary incisors. Mandibular incisors will rebound around 2 to 5 degrees back. If they are flared, they will go back. And after the Forsus spring is removed, and keep the non-activated appliance at least for a 1 appointment interval so that the settling take place. It's very important. This is how clinically the case should look when you are going to remove the Forsus appliance. It should be overactivated, little overcorrections. It's very important. So Forsus removal protocol, we should remove the appliance, replace mandibular arch, and it was a very sturdy stainless steel wire, change it with the 1722 super elastic nickel titanium, chain a mandibular arch if there are spaces present or to increase the mandibular incisor rebound because the incisors will go back, leave maxillary arch in place, chain maxillary arch if spaces are present, and you can use vertical elastics or box elastics for interdigitation, very important. So it gives you average Forsus appliance to correct the class to take around 6 months in growing patients. It takes 5 to 6 months. Some patients will finish in 4 months. Predictable treatment results, wide range of application, stable, and it is durable. So somehow or the other, the alpine is much better than EZ module. You can adjust it. You can move the distal portion of the alpine more buckly so that it doesn't interfere. And it has got, it gives you more in transverse deficiency cases where there is a constricted upper arch. The alpine is better, or molar is rotated, or the band position is rotated. It is difficult to put these EZ module on those cases. Now, if you have got like here on this side, the spring is very close to the side A. So we should move it with the alpine adjust so that it is like this. We should otherwise there will be rolling effect and your molars will move out, because if it is overactivated, it is very, very important. Inadequate maxillary transverse dimension can cause the spring to rotate horizontally as the patient closes, adds an unwanted force factor, resulting in the rolling of the molars. So inadequate width or rotation distorts spring with function when you open and close. And use an alpine adjust for the width. You can adjust it buckly. So rolling of the molars, you see the lingual cusp resulting in interference from the hanging lingual cusp. This is all happens because of the overactivation. So this is how you should adjust the alpine from the distal side with a Weingart plier, move it more buckly, and it will give you much better results. Why use an alpine occlusion tube with the alpine? Because it's more adjustable in vertical direction to vary the force factors you can use in cases. Let's talk one case. This is a very interesting case, and we published this case in the AGODO. And this is a class 2 deep bite case of mandibular region, mandibular occlusal plane, and wire selection. So optimize this thing. So here, bite opening in the mandibular arch is a 100% deep bite case. So when you have got a very deep bite case, more horizontal component you require. So you can put this spring distal to the canine. Let's see this case together. So this is a deep bite case with a crowding, needing mandibular incisor intrusion, and also the extrusion of the segments. So here, this is the ceph and the OPG. You see the mentolabial sulcus, that kind of retrognathia it has got. And then in these kind of cases, there's no need to level the arches prior to the class 2 correction. Bite opening can be accomplished with the forces in place. Factors associated with forces can enhance the opening mechanics. So maxillary and mandibular arches do need to be coordinated with the transverse dimension prior to the forces placement. This is very important. Maxillary transverse dimension must be wide enough when the mandible is in class 1 position. So options exist with the forces that do not exist with the class 2 elastics, leveling mandibular occlusal plane through the posterior extrusion, increase lower facial height, increase posterior vertical dimension. So that's what I'm talking to you. It can combine extruding posterior teeth and intruding the incisors. Swipe reverse, you can put a reverse cup in the lower arch like a beta titanium wire to intrude the incisors. Posterior teeth are extruded after the forces is removed using the vertical elastics. So in this kind of a case, we have used the occlusal tube attachment of the spring module. A posterior open bite will be seen with the forces in place. And this is the curvo SP is not leveled before forces is placed. Posterior teeth are extruded after the forces is removed. After the forces are removed, you can just use vertical elastics and level the occlusal plane. You will see a posterior open bite during class 2 correction because the mandibular occlusal plane will not be leveled until the forces is removed. So this is the case to start with. So how we are going to treat: align upper and lower arches, coordinate the maxillary mandibular arches in the transverse dimension, place in the mandibular arch in 1925 beta titanium wire with the bite opening curve, and place the forces appliance. Activate forces until occlusion is corrected. Then you remove the forces and use 1725 stainless super elastic nickel titanium wire and box elastics. This is 3 months into treatment. This is, if you see it here, this is super elastic nickel titanium for 3 months. This is super elastic nickel titanium. And this is how the upper and lower arches, 3 months. Then we use the tandem wires. Tandem wires means you have got 014 and 016, 2 wires in the same slot removed. And then we switch. After 6 months, we put 1725 super elastic nickel titanium wire 7 months treatment, pre-forces. And then it is just leveling. Then to increase the maxillary transverse width, use a flexible maxillary wire like a nickel titanium super elastic wire in the upper and stainless steel wire, rigid wire in the lower. So slight narrow in the posterior maxilla when the patient is postured into a class 1 position. So we expanding with the Forsus appliance on a nitinol wire. This is how the expansion takes place in the upper. The Forsus spring is cuspid location for increased intrusion of the incisors, places spring more horizontal at correct activation amount. So this is 10 months into treatment, Forsus 3 months. And this is bite opening in the interior is happening because of the reverse curve wire, which I put in the beta titanium wire along with the Forsus. The effect of both, this is intrusion. Posterior extrusion will be and after class 2 correction, and when Forsus is removed, we will correct that. I have already discussed. And this is after the Forsus are removed, we use vertical elastics and then box elastic and use nickel titanium wire in the lower also, soft wires. And this is 8 weeks, 17 months treatment, Forsus 7 months. This is 18 months treatment. Then we use nitinol springs to close the gaps, most effective. And this is closer to the finishing, and it took 24 months to correct this. This is before and after. This is before and after. This is 18 months of the treatment. This is, sorry, go back. So this is before, this is after the Forsus are removed, and this is the post-treatment. Ability to modify and activate after initial placement. If you start initially with the distal to the canine, you can shift distal to the premolar later on after you have achieved your goals. As I explained, that first premolar is always better. Maxillary, so this was the deep bite case. Let's talk about another patient where there's the deep bite consideration, second molar considerations. You know what happens when the minimum, it minimizes the intrusion force on the posterior maxillary dentition. So minimize the intrusion force on the posterior maxillary dentition. So what we do is we don't take the second molars into account in these kind of cases to avoid intruding the maxillary second molars. Because if you intrude both first and second molars with the Forsus appliance, your bite becomes your bite opening will become difficult. Shashank?
Sir, wait an hour, you can click, sir. Click on wait an hour.
Okay. No, this has gone back. Can you hear me now? Hello?
Yes, sir. Yes, sir.
Okay. So let's see the second case. What is the maxillary second molar consideration in deep bite cases? So when you have got a deep bite cases, it's better to not include the upper second molars in the system. Stay off the maxillary second molars to avoid intruding the maxillary second molars. Intruding maxillary second molars can deepen bite, decrease posterior vertical dimension. Second molars can act as posterior stops if left unbonded, because you know the nature of Forsus appliances, it will intrude the upper molars. Maxillary first molars will respond to the intrusive force. Intruded maxillary first molars will rebound after the spring removal. So this is how it works. Stay off the maxillary second molars. Place Forsus as horizontal as possible. So if first molar intrudes, second molar act as a vertical. This is what it has happened. Molar intrusion with Forsus acting as second molar acting as vertical stop. The first molar will rebound when spring removed and flexible wires are pulled. So let's talk about this patient. He is 13 years, 6 months old, and He has got crowding. He has got a deep bite. This is the CEF to start with. So we started with the leveling over 9025 superelastic upper and lower wires. And then we placed it firstly at the canine to obtain the correct activation and angulation of this. And then Forsus moved to the bicuspid after a few months to activate and control the mandibular incisor positions. This is how the bite opening is taking place. And this is what happened with the first molar intrudes, but the second molar is working as a stopper. So if you include second molar, you will have deep bite. The forces are removed at this point, and the box elastics start mandibular arch 017-025 superelastic nickel titanium and maxillary arch 019-025 superelastic. And this is after the settling, occlusal settling with the box elastics. And this is closer to the finishing. And first molar rebound after the forces are removed, the mandibular 3-3 fixed retainers deboned at 15 year 8 months. So after you have removed the Forsus appliance, you can level first and second molars together. So this is a very important point, that don't include your second molars in the initial stages. This is 1 year retention. This is before and after. So let's talk about another case where there is a class 2 malocclusion with deep bite, anterior maxillary vertical excess. So bite opening in the maxillary arch. We already seen the bite opening in the mandibular arch. So force factors associated with the forces and intrusion arch. This is arch where it is very, very important. As you know, if you put an intrusive arch or a arch with a reverse curve SP, it will lead to the intrusion of the upper interiors and extrusion of the posteriors. But the intrusion with the Forsus appliance will nullify the effect of the extrusion with the arch wire. So that's how you will get a total effect, only the intrusion of the upper interiors. So let's see this patient, Safia. She has got a gummy smile, 100% deep bite, retrusive mandible. To start with, this is a gummy smile, 100% deep bite. What are the objectives? She has got deep bite, class 2 malocclusion, maxillary vertical excess with excessive gingival display, slightly mandibular retrognathic, correct class 2 malocclusions, intrude maxillary interior incisors, and reduce gingival display during class 2 correction, and correct the AP discrepancy. So this was a case started with a smart clip, except we use sequence, plays a maxillary 019-025 nickel retained with intrusion arch curve during class 2 correction. And this is, we use the intrusive arch in the upper. Pre-Forsus. I'm not going into details in this fellow matrix. This is 5 months of the Forsus aware. And this is final at the debond. And this is how it looks. Changes from pre-treatment to post-treatment. And this is the final results. If you see here how the profile has improved from pre to the post. So this is was before and this is after. And then we did a little laser gingivoplasty to correct the gums, anteriors. So this is the post-treatment. And this is the pre and post. Pre and post. This was starting, and this is the final. This is starting, and this is the final. So let's talk about maxillary resistance considerations in treatment response. So the Forsus appliance, it depends upon how much amount of resistance that exists, or you can add into either arch wire will determine the treatment response, whether you have got a flexible wire or you have got a rigid wire, and what is your aim to correct it. The Forsus spring in the rod creates an equal and opposite direction to the maxillary arch, to a maxillary and mandibular arch, as we discussed before. So if you are not distalizing, you can cinch it. Once a wire is cinched, it will be harder to remove if you want to change the arch wire, or you can just tie it with a crimpable hook. Secured elastic ligature to control the tension is able to easily change the arch wire in those cases. Or this was one. Secondly, you should always chain to control the molar distalization and keep arch wire consolidated. If you are distalizing, then do not cinch or tie back arch wire and leave the long little wire so the molar can move back, and leaving maxillary arch wire long out of the back of the tube helps with molar control during the distalization, avoids backing of the wire. Spring modules will keep long wire from contacting the cheeks. Now, if you are distalizing, then you must keep some extra wire. Otherwise, it will lead to the rotation of the molars. So check the length of the maxillary arch wire at every appointment to avoid backing of the wire if you are distalizing with the Forsus appliance. So let's talk one case with the open bite. So when you have got an open bite, you need a vertical factor, vertical force factor. You need more of the intrusion of the upper posterior segment. So you should select the L pin with gingival tube so that you get more vertical effect. So here, minimize the intrusive force, vertical installation, and flexible wire. You should use a flexible wire and maximize the intrusive force on the posterior segment. Very, very important. So this is 13 years, 7 months. She has got an open bite. So she has got an open bite, and she has got a habit, tongue thrusting habit. So this was to start with. So what was the case analysis? It is open bite with a reverse smile due to the intruded incisors, severe overjet, generalized maxillary mandibular spacing, excessive lower facial height, mandibular retrognathic, slight maxillary protrusion, previous thumb sucking, current tongue thrusting. So this is the problem list. So what we plan to do, maxillary expansion with combined expansion and habit appliance, maxillary mandibular fixed appliances, and then the Forsus appliance rod, which is placed at the first bicuspid, maxillary spring attached at the L pin through a gingival headgear tube to maximize intrusive factor of force. So this is the expansion screw, which we started along with the habit breaking appliance with the crib. This is 6 months after forces are removed. The intrusion, see the effect of the intrusion, and 31 months of treatment, so we could correct the interior open bite. 6 months of Forsus appliance. This is before and this is after. This is before and this is after. This is before and this is after. So if you see the CEF, this is before, after Forsus and post-treatment. So I'm not going into detail of this sphelometric analysis because this is one of the articles which were done by Frankie and Lisa together. And they found out between the Forsus group and the control group, they selected 32 subjects and average age of 12 years with the Forsus, and then they have a controls, total 27. And the Forsus appliance took around 5.2 months. And what they could find out, of course, it restricts the growth of the maxilla as compared to the control minus 2.1 degree. But the mandibular length increases like as compared to the control like 1.8, but the flaring of the lower anterior 6.1 degree. So this is what they found out. The Forsus has got a favorable skeletal effect on the maxillary structure by restraining the sagittal advancement of the maxilla. The effect on the mandible are mainly at the dental velar level, with a large amount of propionation of the lower incisors to be limited. So let's talk about Forsus for the asymmetrical cases. This is a patient with a deep bite and severe crowding. And so basically, in this case, we distalize the maxillary molars. So it has got a class 2 with a maxillary midline discrepancies. Forsus used as a unilateral maxillary dental distalization appliance. And after maxillary correction, we'll correct the, sorry, this is, after maxillary correction, Forsus will correct the class 2, this thing. So here is a class 2 side, this is the class 1 side. Mandibular midline is correct, but maxillary midline is deviated. So what we did is, the Forsus placed bilaterally, active side for correction, inactive side for vertical support of mandibular occlusal plane, standard mandibular arch, allow maxillary dentition to distalize on class 2 side, and secure maxillary arch to limit distalization on the class 1 side, post and back maxillary arch wire. Just to explain this case, so I made these pictures. So what we do, this is an active side. We are distalizing this side with the help of Forsus appliance. And If you see it here, sorry, this goes back. So here it is a passive spring. So we don't want any distalization, and we tied the spring wire with the hook with the elastic module to limit the distalization on this side. And here is the spring. So what we did is we use active on class 2 side, passive on the class 1 side, and then we moved the molars back, molar distalized first molar on this side, tie back to molar to limit maxillary extension. And then with the help of coil spring, we distalized the premolars, and the Forsus is holding like a headgear on the molars, doesn't allow it movement. So we move with the spring, the premolars, and then we move the canine back. And then we nitro spring retract the cuspids, and then we put a hook to move the lower upper anteriors towards this side to correct the midline. And we put 2 hooks here. And at that time, we remove this wire to slide the wire towards this side, the elastomeric module, which we have put with the hook of the Forsus appliance. And this is how the midline is corrected. And then we closed on both the sides with the nitinol springs. We closed the interior gap. And this is how we corrected this. And this is the finished result with the Forsus appliance. This is midline correction as well as pre-treatment and post-treatment. So let's talk about the extraction cases. This is the last case I'm discussing with you. Forsus used to maintain, Forsus is a wonderful appliance. You can maintain the maxillary molar position like a headgear, and you can use to maintain the mandibular incisor positions. Because in normal cases, if you retract bring the lower posteriors forward, your incisors will be retruded and you will have a bigger overjet. But with Forsus, you can maintain the position of the lower incisors. So there's a distal force with the Forsus, and there's a mesial force on the lower interiors, and it exerts 200 grams of force. So what we use is we use a nitinol spring to close the extraction spaces. So what it does is, it puts 200 grams of force. If you use the nitinol springs, the force direction is in the backward direction. The force of the Forsus is in backward direction. The nitinol spring in the forward direction. They nullify. The maxillary molar remains in place while the interior teeth are retracted. The mandible and lower anterior teeth maintain their position, with the mandibular posterior segments move forward with the nitinol springs. And they set up demonstrated in a patient. So this is a class 2 case. See the acute nasolabial angle, and this is we prepared the encourage for the extraction cases. So this is the kind of an overjet. So we extracted upper first premolars and lower second premolars in this case, and we have to go to rectangular wires when we go over to the Forsus appliance. So we put the Forsus, when we Forsus appliance are put, then only we start the space closer, because you are getting upper Forsus acting like a headgear for you. Your lower Forsus is controlling your lower incisors. And then we bring the lower posterior forward with nitinol springs, and we close all the 4 segments together. So this is how we can use the Forsus appliance even in extraction cases. This is the post-treatment. This is the pre and post. And this is the post-treatment results. Pre and post. And this is before and after. This is before and after. This is before and after. Because we had to extract in this case because there was too much of protrusion and the nasolabial angle was very acute. So this is the profile, the frontal views. So another thing which I started doing around 10 years back. So when you have got a lower incisor, too much of flaring, you have to be taken into consideration, put microimplant between 4 and 5 or between 3 and 4 and hold the position of the incisors. Very, very important. Forces with micro to prevent the lower anterior flaring. The other thing which with 3M has come out with the wire mounted. You don't want to put a band, so it come out with a small appliance like it goes into your wire, and you can tie it with the buccal tube of the first molars. You can put it mesial to the first molar, or you can put it distal to the first molar, and you have to tie them together with the elastomeric, as we have with the elastomeric this thing, and you can put the Forsus appliance into this wire mount. Some patient in between the treatment, you change your plan, you want a class 2 corrector, so you can use a wire mount module. It will stabilize the wire and with the bracket to avoid any sliding of this. So this is the completed portion with the wire mounted version of the Forsus appliance. This is a patient with a wire mounted stuff. We may need to adjust the pin length out, so we can. This is how it is used, the appliance. So we should also evaluate the vertical factor at the first bicuspid area, because in these cases the distance is very, very small. So sometimes you go distal to the first molar, because when you select the road in wire mounted modules, mostly in first bicuspids, or if even vertical factors, you can go even to the canines, because the distance is different now. Still, tie ligatures, convertible maxillary first molar bones need a reliable molar bracket and bone technique. Equal forces placed on the bicuspid bracket, convenient for the patient, no treatment plan for the forcer. Eliminates need to change out bands because they do not have the headgear tube. Easy adaptation for clinicians, easier installations, and more adaptable and adjustable. So this is the options for you. You have got an EZ module, you have got an L-pin, you have got L-pin in a occlusal tube or in the gingival tube. You have got a you can apply it distal to the first premolar, distal to the second premolar, distal to the canine, and you can use it. You can use it on the wire mount module as we discussed. So you have got a lot of options available depending upon the need. To optimize force factor depending on the treatment objectives, vectors can be selected pre-treatment or modified the mid-treatment. You can go from canine to the premolar or vice versa. The vectors are selected based on the cephalometric analysis as related to the lower facial height and mandibular plane angle. If you've got a high angle case, go for vertical factors. If you've got a low angle case, you can go for the canine. The amount of overbite, or like an EZ module, amount of overbite is also considered. So optimize force factors depending upon the treatment objectives. Vectors can be modified mid-treatment. Rod can be placed at cuspid, bicuspid, omega loop, or lingual arch, and spring module can be attached at occlusal tube and EZ2 module, occlusal tube and L-pin, and gingival headgear tube and L-pin. So combination of rod location and spring attachment location controls the amount of horizontal and vertical force factors generated by the Forsus appliance. To optimize forces results, consider treatment timing, factors generated by the appliance, varying rod and spring location, resistant in each arch. You can have a flexible wire or you can have a rigid wire, depending upon you want an expansion or you want a rigidity. Wire selection and treatment response. And what are the clinical concerns? If you overactivate, you land up in rolling of the molars, and you can move the lower interiors forward. Steel wires, you should always put in the canine and the premolars. Loose or broken ties, you will always look for. And overactivation leads to the debonded brackets, bonding technique, not using the guard under the wire. Tipping of the molars always leads because of overactivation, short maxillary arch wire not fully engaged in the tube, inadequate transverse. You should always see causing spring to displace unbonded second molars prior to this thing. Advantages: very easy to install, 5 minutes to put my Forsus appliance, durable, consistent and predictable results, accepted by the patients, independent of patient compliance, and variable appliance configuration selected by the orthodontist, depending upon the way you are installing and activating. With this I contributed in the book on fixed functional appliance chapter in Dr. Bill Clark's book. And now we have come up with a new book on the fixed functional appliances, which is published by Elsevier. Thank you very much. Thank you, Dr. Kapoor, for this invitation, and Dr. Jitendra Kumar for being there.
Thank you, Dr. Ramesh Sabluk. That was an excellent presentation. You have comprehensively covered the entire
Thank you so much.
of Forsus therapy.
Thank you. Thank you so much. Is there any questions I can answer?
Yes, please, Dr. Sabluk, as moderator, if you please open that panel on question and answers. There are 9 questions waiting for you.
Yes, sir.
You open the question
Thank
and
you
answer,
so
and
much,
you
sir.
can answer them live.
Yes, sir. Yes, sir. Thank you so much, sir, for your excellent presentations.
Thank you.
Heading forward for the panel discussion and the question and answers. We have with us chief panelist, Dr. Jatin Kumar sir and Dr. Pradeep Raghav sir. So we have questions. So I shall be asking the questions, sir.
Sure, please.
Dr. Vidya Bharti has asked that what happens when we use overlaid bracket slot and how much amount of anterior flaring can it cause?
So the question is, as I explained to you, the lower flaring will depend upon how you are installing the appliance. So if you follow all the basic principles, that you cinch the arch wire at the back, you do the splinting with the ligature wire, you don't overactivate the appliance, you remain within this 200 gram of force, select the right size of the rod, then nothing happens. You don't need to even go for a TPA or a lingual arch, which I used to do in 2001. You have to use milder forces, and that will take care of that. And after 3 to 6 months, you can take a ceph and see that whether you are flaring or not. But one thing I must tell them, that if the patient has already got very anterior flaring, then you should either think in terms of extraction or put a microimplant and retract your lower anteriors to get a better mandibular projection. You cannot have a very good skeletal projections until as your lower anteriors are not controlled. It's very, very important. So all these measures which we discussed, that depending upon the measures you have to take about prevent the lower anterior flaring, you have to cinch nicely, use a rigid wire, use the splinting of the ligature wire, don't overactivate it. These are the measures to prevent the lower anterior flaring.
Sir, I can add one more thing. Basically, what she was asking regarding that whether we should use an overhead slot or O2 slot. Since no, sir. Actually, my question is, sir, since for preventing the lower incisor proclamation, we need to have a rigid wire. So probably my thought is that if we use a O2 slot, then using a 1925 wire would give a much better torque control as compared to a 1725 wire in overhead slot.
It is always there. We know most of the people around the globe, they use O2 slot.
Yeah,
maybe 30% people on this planet use A18 slot. So very few.
Thank you, sir. Dr. Nikita Baheti has asked a question: how to select the size of the push rod? Should it be measured in normal retruded position or in protruded class 1 molar relationship?
So as I already discussed, it should be in centric relation and centric occlusion, and take the ruler which comes along with this appliance, keep it on the distal portion of the occlusal tube, and then go over to the lower arch, whether you want to keep the rod distal to the premolar or the molar or the stop, like a gradient lock or whichever you select that size. And if that size is 22, take 22. If that size is 25, select 25. And the right and left is different. You have to select both the sides. If your rod is coming in between two, for example, the ruler, then select the smaller size. Overactivation is the problem of all the things in Forsus appliance. You get flaring, you get rolling of the molars, all the problems. If you are having milder forces, I'm telling you after more than 20,000 cases. So just overactivation leads to problems.
Thank you, sir. Dr. Ravi Jam has asked the question: your opinion on advanced sync as fixed functional appliance? Would you prefer to go for rigid wire and then put it as prescribed by them, or you will put it on the day one and catch hold them on the growth? Your opinion.
So can you repeat the question once again?
So he just wanted to ask your opinion on the advanced sync as a fixed functional appliance. And then second question is, like, would you want to go for a rigid wire and then put the appliance, or you want on the day first you want to put the appliance and you just want to catch hold of the growth?
You have to firstly level the arches, reach to the level of over 9025 stainless steel wires. Then in the lower arch, more the rigid wire in the lower arch. Upper arch, you can select, as we discussed. You can have a flexible nickel titanium, you can have a beta titanium, depending upon what is your goal. If you have got a patient with a very deep gummy smile, you can have a upper nickel titanium wire with an intrusive arch, and you can still, but lower arch should be always rigid. because you are controlling your lower anteriors. And if you get lower anterior flaring, your skeletal correction is gone. So this is very important. So
As well as
you reach the level of 019, 025 stainless steel wire in the 022 slot, don't put the Forsus appliance.
yes, sir. And if the patient is growing patient, we can definitely give a twin block or any functional appliance.
Yes, both of them works. But the question is, I will prefer 11, 12-year child a twin block. But some people who are not compliant and all those issues, even 13, 14, I've treated with the Forsus 17, 18, 19 years old also, it works. But when you go the age higher after the growth, what happens? You get more of a dental effects, less of a skeletal projections, but still works. And now if you see Sabine Roth and Hans Purchase in his latest seminars in orthodontics, they have seen an adult patient they are treating showing changes in the TM joint with the Hobst appliance. So it works. I've treated the last patient I treated with the Forsus was 25 years old. It worked.
Again, the question is from Ravi Jam. How to address asymmetrical mandibular advancement to correct the skeletal facial asymmetry in skeletal class 2? And one more question is there, that advancing 2 and Forsus, which one is better in growing patients? Kindly share your opinion, sir.
So the first question
All
is,
the panelists can answer the questions, I think. Yeah.
you know,
Yes.
Forsus is a very simple appliance. It's a patient-friendly appliance. You can put the Forsus appliance in 10 minutes time, you know, if you have already planned for it. And these days, the wire mount module has come. You don't even select a band. You just put this wire mount on the wire, and you can just put it. Totally takes 15, 20 minutes to put the appliance. Rather than making life miserable, lab procedures, other things, make life simple, what I feel is that is very important. This is one aspect. Asymmetrical, as I discussed with you, I showed you one case of class 2 where we distalize we have to see which segment is problem. Firstly, you diagnose where is the problem, whether it's with the maxilla or the mandible, and accordingly we do the distalization on that side and correct the class 2. One side is active, one side is passive. So I don't know what asymmetry is talking about. He's talking about asymmetry of the face or asymmetrical occlusion. If asymmetry of the face is a different subject altogether.
So your opinion, Dr. Pradeep Raghav, sir, on the advancing and Forsus?
Okay, actually,
Which one would you prefer?
both the appliances are very good, and actually it depends upon the experience and comfort with which you want to give this appliance. But my opinion regarding the treatment of asymmetric, I would say, is that because the Forsus is much better in correcting the asymmetry of the dental arches. Probably he must be asking about the asymmetry of dental arches, because in this we can use asymmetric placements of the rods. Okay, but in advancing 2, actually it is a molar to molar corrector only. So the correction of asymmetry is also, although it is possible, but it would be much better, or much better can be achieved by Forsus appliance. I think Dr. Ramesh Ablok sir can tell much better.
It's a distalization is some subject which is very close to my heart, and I'm speaking on this for last 30 years. When you're using a gingival tube, you know, you are vertical pattern. You are closer to the center of resistance, and it is much easier to distalize the posterior segment faster because you are, you know, with the Forsus appliance. Because one side you make it active, other side you make it passive.
Yes, sir.
So, and because you can select the location of the tube or the location where you are putting the rod. If you put the rod gingival tube more vertically, you get more closer to the center of resistance. You get better distalization with the Forsus appliance as compared with other fixed functional appliances. So,
Jyotin Kumar, sir, I would like your opinion also on this.
Yes, I think I fully agree with Dr. Sadlok. Facial asymmetry in its true form is an entirely different condition which is not addressed by Forsus. You could be looking at facial hemimicrosomia. You could be looking at a condyle hypoplasia. You may be looking at a growth deficit unilaterally subsequent to trauma. So asymmetry is a very broad issue. I fully agree with Dr. Sadlok that it is an entirely different subject. I would like to ask Dr. Sadlok, is the rigidity of the Forsus appliance a little too much? You remember there was a similar appliance called the Jasper Jumper, which was marketed by Orumco, which I've used extensively. I found it a little more flexible than Forsus. Your opinion, please?
No, actually, Jasper Jumper was with the American Orthodontics. It was a very flexible appliance, but the kind of springs which 3M has come out, coaxial assembly, they have done like 500,000 type of, they have closed and opened the springs, and still it is fatigue resistance. It doesn't get spoiled. Whereas the breakage and all those with Jasper Jumper used to be quite a bit. But this is more sturdier appliance, this Forsus appliance.
True, they are robust, but in class 2 correction is rigidly preferred.
No, this is not absolutely rigid appliance. This is also flexible appliance, but the point is the kind of coaxial assembly, the coaxial assembly spring. It's
far more resistant to deformation and fatigue fracture compared to Jasper Jumper. But I also thought that the flexibility that this Jasper Jumper and similar appliances afford gives the patient a little more latitude to chew and be more comfortable with the appliance than would be a hard appliance. If you look at the Pancho's appliance, it's pretty rigid. This is my personal viewpoint. Everybody has their own theories.
I respect your point. The point is this, I'm just telling you, when we put a Forsus appliance distal to the first premolar, I'm just telling you, it doesn't go over to the cheeks. It almost same in the same profile. So only thing is, it is also very flexible and very comfortable appliance. We also see patient comfort also. This is flexible and very comfortable appliance.
Yes.
We have a question from Dr. P. Harikrishnan. Nice case illustrations. What's the implication of Forsus on TMJ in older patients?
You see, basically what happens, there are small changes takes place in the TM joint, but which is positive changes. But when you see the changes which in the active growing period, and we used to say always there's the repositioning of the glenoid fossa, there are changes taking place in the condyle, is not to that level, is much less changes in the adults. But these are all very positive changes in the TM joint, and there's nothing to worry about it. Because most of the time we use this appliance in the adolescents or early adult patients. We don't use in very late patients, and we have not did that much experimentation.
So, hey, I could add one. Actually, recently I've read one systemic review, and in which they have compared between the rigid, the Herbst appliance, and the Forsus, because Forsus is a semi-rigid appliance. And they have said that semi-rigid appliances, they keep the condyle centered in the glenoid fossa. And they are much more gentle on the TMJ as compared to the rigid appliances.
Definitely. They're much gentle. We have, in fact, in my book on Dr. Clark, I've added this point, the same word which you are speaking, that this flexible, we did tomograms and we did studies with the 3D, with the TM joint in our cases of Forsus appliance. It works out excellent. No problem with the TM joints at all.
Thank you, sir. Dr. Bennett Babu has asked a question. What are the chances of breakage of Forsus, and how much patient compliance is there in comparison to other fixed functional appliances?
There, so far, 0 chances of breakage of the Forsus spring. The only thing which can break is the brackets. The brackets will only break when you overactivate it or your bonding is not correct. In my last 21 years using Forsus, I don't think one case of a failure because of the Forsus appliance. So it doesn't happen. Sometimes patient opens the mouth too much, the rod can come out of the spring. That we teach to the patient, that how you put it back. And we actually, in my practice, I always give brochures and USBs, how to use for patient instructions, everything to the finer details. So I don't find even 1% chances of breakage. I have not seen. Even Lisa, I spoke to her. She's the godfather, and she's the lady who invented this appliance. Hardly maybe less than 5% chances.
Thank you, sir. Dr. Ravi Jam has asked the question. Patient's overjet is 12 millimeter at the age of 19 years. As a male patient, should we go for fixed functional appliance or surgical? And the results of fixed functional appliance in adults are stable or not?
You know, this is a mixed feeling. It can result in the positive results. There's no doubt about it. One can try. Because once the growth is over and you go to CS5 or CS6 of the CVM method, which we discussed last time, then it becomes more of a dental effects than the skeletal effects. But one can try. Sometimes the upper arch is very constricted. You can expand a little bit of the upper arch and bring the jaw forward. It works. I have tried, last was 19, 20 years patient. It worked. So one can try. There's no harm.
So I would request Dr. Pradeep Raghav sir to add his opinion.
No, actually, it was such a wonderful presentation. Actually, whenever I have a question in the mind, next to following slides of the sir actually always answered that question. Especially because most of the systemic review on fixed function appliances, especially Forsus, they say that there is actually more of procrustation, but sir has given a lot of tips how to prevent the procrustation of lower anteriors using the -6 or -10 torque brackets, and the most important, cinching back. Because what sir has rightly referred, that actually sometimes we used to just do bend back, but it has to be a cinch back, tight cinch back against the distal part of the tube. I think that is a very important point. And then again, the overactivation of the appliance. Again, we have to see that overactivation should never be done, because it can always lead to buccal procrustation, buccal flaring of the molars. So there are many important points. So thank you very much, sir, for a wonderful presentation.
And actually, one more point which I wanted to add is, we should always see the upper arch, that it is wide enough to receive the lower arch. Because that is one point when Forsus appliance, the molars roll out and the lingual cusp come down because you are overactivating.
Yes,
So
sir.
expansion of the upper arch, if it is very constricted, better go for rapid palatal expander first. Or as I explained, that better use for a L-pin module where there's more adjustability as compared to the EZ module. EZ is very easy to click. And
Yes.
L-pin, you have more chances of buckling. You can adjust it so that it doesn't interfere with the occlusion. That is much better. And L-pin, you can use it for vertical growth patients like open bite cases. Eyes is wonderful because you can have a gingival tube and works excellent in open bite cases and
Yes,
tusion.
sir.
And deep bite cases, one tip which I have given, that don't bond your second molars initially. Leave it separate, because your first molar will be intruded and second molar will act as a stopper. So after you have corrected the class 2, just level it together. This is one I've written in my book also.
So just one more question, just especially if we are using it in a vertical grower. So if we are keeping the lower end just distal attached to the first premolars, it would be much better, or to the canines, because in a vertical grower.
Never in canine, never on vertical growers canine.
Okay.
You have to use a more intrusive action. Rather, if allows, if you are when you select the size of the road, if it is allows even second premolar,
Okay.
you can go for more vertical effect.
Yeah.
You're right. You're right.
Dr. Preeti, there are some questions on YouTube.
Yes,
Would
sir.
you like to take it up, or shall I place it before
Yes,
the
sir.
panel?
Yes, sir. Yes, sir. Please.
Sir, there's a question from Shahzad Ahmed. If we put a micro implant on the mandible to prevent lower anterior flaring, will it interfere with dento-alveolar movement of lower arch, as after puberty mainly dento-alveolar corrections can be achieved?
No. Basically, we are controlling the lower anterior flaring of the incisors. Those cases who have got very IMPA is very high, or their incisors are flared, better to take control of your lower incisors first. Or if you cannot, suppose there is a problem, better go for extraction. Upright your lower interiors, then you can get skeletal projection of the mandibular projection. Otherwise, you will never get mandibular projection. What is our aim is to get a nice profile. Profile you will only improve once your lower incisors are not flared and there's more skeletal effect. So micro implants, I have done more than 100 cases We put between 4 and 5. And those patients in which more than 105 degrees IMPA. So we try to keep it under control so it doesn't flare with the pressure of the spring. So that you have to take into consideration. Nothing happens, other things. But of course, in the growing patients, you have to be very careful that you use very mild forces on the microimplants. You have to be very gentle.
Okay, sir. Sir, Shahzad Ahmed further has raised one more question. Please shed some light on retention protocol after FRD treatment.
Same protocol, lower canine to canine retainers, fixed retainers. Upper, we can use a removable. It was a very large overjet. Then you can have something with a bite plane, inclined plane, like we use it for a sport appliance in twin block cases. But normally you don't need it. And as I explained in my cases, that you leave this after the correction, leave this Forsus appliance for 6 to 8 weeks, passive. That gives you extra retention because there's chances of 10% relapse. That doesn't happen if you just leave it for 6 to 8 weeks passive after the correction. So normal, like upper Hawley retainer with the fixed, you can use upper and lower fixed retainers along with the upper Hawley retainer. If your bite was very deep, you can add with a small sport appliance like this, but normally you don't need it. And I have seen my cases after 5 years, after 10 years, after 20 years of finishing, it stays excellent. Yeah, as long as your quality of orthodontics is good.
Longer stability is desired.
Oh yes, very important. And that depends upon the posterior intercuspitation and also the interincisor relationship you have produced. That gives you because we do a lot of vertical settling. And that settling,
in order to have a longer stability, you need to give retention appliance for longer time.
oh yes. You definitely need at least for a year, year and a half to 2 years. And
this is what the intention of the question is.
Definitely.
I have an observation, Dr. Saplok. It has been my experience that given the ethnic population that we have in South India, sometimes by the time we correct the class 2 and establish a class 1, we also find that you have a bimaxillary protrusion that has crept in, and invariably you have to do a second phase of extraction correction. So this question has always bothered me. So could we have gone for extraction to start with without a class 2 advancement phase, or are we better off, the profile's better off with advancement and then followed by extraction? What's your experience over the years? I've also been doing this 40 years. Sometimes it has bothered me taking 2 phases. It's 24 plus another 12 months, sometimes 36 months. Was it worth the effort? Is it appreciated by the patient? Is the profile better with advancement followed by extraction, or should we have
you are talking about surgical advancement? You are talking about
No. Class 2 advancement, we start as phase 1, correct it into class 1, then the teeth are in bimaxillary protrusion. You have to do a premolar extraction and improve the profile. So there's a bimax that is superimposed on a class 2. When you do an advancement, you have corrected it to skeletal class 1, and then you eliminate the protrusion with extraction. Have you seen these sort of cases in your practice?
So, what I do is I'm just telling you, I am basically believer, and I'm just telling you my view, that right. I basically believe in non-extraction most of the cases. But if the case is very much protruding, severe crowding, I do a simulation results and how it will look with extraction and how it will look without extractions. And in simulation,
I saw your patients, they are all, the population has very sharp noses and posteriorly diverging profiles, so it works beautifully. But in our South Indian population, where there is so much of bimax, as you know.
South India, there's a lot of bimax. I know that.
Yes.
So what we do is, if it is a very severe crowding and we see nasolabial angle is acute, I just straightway go for extraction. But once we prepare into the rectangular wires and we have prepared the upper and lower arches, then we go for the Forsus. And once we have corrected the class 2, then we start closing the gaps. You know, the Forsus appliance act like a headgear in the upper, and it maintains the position of the lower incisors. So it can beautifully close the gaps with the nitinol springs because it counteracts the force of 200 grams, both arches, beautifully. So if the case is very severe and bimax, you think it is an extraction case, please go ahead. Otherwise,
Right.
end of the day, is important is a beautiful profile,
That's right. And a good smile.
a good smile. That is important. So the last
Right.
case which I have shown, I did simulation. I showed to the patient, look here, you look like this. And when I did simulation, I was not happy. So I extracted upper first premolar, lower second premolar, and then I closed the gaps. It came out beautiful, nice profile.
Yes. Yes. The answer is straightforward, but in practice, you quote a fees for a treatment and then you end up doing 2 treatments. And the second one, to get the fees is a problem because you never expected it in the first place. Am I right?
I agree with you.
But Jyoti, you start with Bimax, and that's the reason the problem compounds more than the.
Actually, the early class 2, so the early class 2, when you start at 10 years and 11 years, the Bimax is not obvious because the full dentition is not established. And by the time you have corrected the class 2, the dentition has come in place. And then it looks like a Bimax. Then what do? Then you have no choice but to extract. This is a typically ethnic problem that we face in South India, sir.
Exactly. Very right.
But, samples which Dr. Sablok showed, they're just the right cases for Forsus advancement. They fit in like a T.
They all have a very prominent nose and acute nasolabial angle.
Yes. Posteriorly diverging profiles, they just come out beautifully with advancement.
Right.
Anyway, but it's excellent presentation, Dr. Sablok. I must congratulate you on that.
Very well. Very good presentation and
Dr.
eye-opening.
Kumar, you are a legend in our specialty. And we have high regards for you,
We also respect your clinical acumen. I could see the beautifully finished cases.
So we have come out with a new book with the microimplants with Heman Jung and Biosync Park. So I'm working in some areas, many areas. I work with Bill Arnett on orthognathic surgery. So many areas I'm working.
That's
Good.
very nice.
Very good.
So can we take a few more questions?
Please,
Sure.
please.
Yes. Dr. Seema Lohati's questions has already been answered. Now, Srinivas Kumar, excellent presentation, sir. Thank you. Can you show any case if you have installed Forsus appliance only on one side?
So it is not recommended to put Forsus on one side because you need to support your mandible and make it passive. One side active, one side passive. So if you do it one side, you land up in sort of asymmetries. So it is not recommended to put Forsus appliance only on one side. You can make it one side active, one side passive, but you have to put on both the sides.
Okay, sir. We have one more question from Dr. P. Harikrishnan. Is a reverse Forsus mechanism available for class 3 correction?
But we have not tried, so I can't tell you.
It doesn't work.
Any other question?
There are a couple of questions on our YouTube channel, sir, by Dr. Vidya Bharti. Shall we take it up, sir?
Please go ahead.
First, she asks, is it mandatory to include second molar to act as a vertical stopper at every case?
It's a very good question. So it depends upon if you have got a deep bite case, yes, you should not include your second molars, which will act as a stopper. But if it is an open bite case, you might have to intrude the whole segment back. So you can include that. It depends upon your skeletal pattern and the kind of malocclusion you have. So you have to, it is depending upon the case selection, not in every case. Because in open bite, you might have to intrude the whole posterior segment back. So it's better to include them. But in deep bite cases, because it leads to the intrusion of the first molar, you should not allow it to happen. The second molar acts as a stopper. That helps you.
So she has one more question. How will the lower anteriors are affected when active and passive screws are used on each side? Will there be a flaring on active side alone?
No, the flaring will only take place when you overactivate. Flaring will only take place when you are not cinching properly. Flaring will only take place when you are not splinting. Flaring will take place when you are overactivating the appliance. Otherwise, flaring will not take place.
She further goes on to ask one more question, sir, that instead of taking anchorage from the first molar, can we use micro implants instead? If yes, when they should be placed? If no, any particular reason for that?
This question is a little difficult.
Shall I repeat it, sir, or
No,
we'll
please
forgo?
go ahead.
She goes on to ask, instead of taking anchorage from the first molar, can we use a micro implant instead?
No, the combination of Forsus appliance with the microimplant is for distalization, it doesn't work out. You cannot put the Forsus appliance on the microimplant. Yes, you can use the microimplant in the lower anterior segment to prevent the lower anterior flaring. That's possible, but not to use the Forsus with the microimplant. You have to use on a occlusal tube, whether on the band or on the wire-mounted model, which I showed you.
Sir, last question from her is that, is there any chance of breakage due to its rigidity or during overactivation?
There is no, it's not a rigid appliance. It's a flexible appliance. It will only, something will happen only if you overactivate it. If you are living with your 200 gram of force, as I explained to you, nothing will go wrong. I have not seen one failure in thousands of cases. So it doesn't work. Brackets can break. That can happen, but not the Forsus spring or spring assembly.
Sir, I think so. If we are not taken up this question, that's a question from Diptiman Shukla. In lower extraction cases, do force vector or forces help in holding the lower incisors and moving lower incisors forward?
Oh, yes, this is a good question. Basically, the forces are in the 2 points. One is at the molars, other is the lower anteriors, controls the lower anteriors. The main advantage of the Forsus appliance is that it will control your lower incisors. In normal course, if you bring your lower molars forward, what happens? Your lower incisors move back. It is retracted, and you get a large overjet. Whereas when you have Forsus in place, it controls your lower anteriors. It doesn't allow the lower anteriors to move back. It controls your overjet and overbite. At the same time, you can protect the posterior teeth forward.
Dr. Preeti, I think so we are done with the question and answer session.
Thank you so much, sir. Dr. Pradeep Raghav, sir.
No, I think Dr. Jyotinder Kumar sir should.
Yes, sir. Now, finally, I would request our eminent chief panelist, Dr. Jyotin Kumar, sir, to kindly sum up the session.
Thank you very much, Dr. Preeti. Today was a lovely evening where we had an exposure to non-compliant class 2 correction. This has been a very big issue. During our times when we started out, we had only the Frankel's appliance, the activator. I'm sure Dr. Sablok will remember the times that we struggled with the patients. They will come back and say, sir, I lost my Frankel, I lost my activator. And we just used to dread those days. And then came the 90s and the early part of 2000, where the 6 functional appliances changed the life and gave a new fillip to the growth industry, as I would say. But the 6 functional appliances truly have a great place even today in the armamentarium. Last 20 years, there is a tremendous onslaught from TADS. TADS has also changed the way we look at it, but class 2 advancement has been largely unaffected by the influence of TADS. And these 6 functional appliances is truly a valuable tool in the armamentarium of the modern day orthodontists. No doubt, as Dr. Sablok rightly said, the biggest problem with all these advancing devices is its impact on the lower anterior dentition. Invariably, I've seen even for postgraduate exam cases, IMPA going as high as 110 degrees. And then we say, what do you do after this? Are you going to retreat these cases? So this word of caution is very, very important to all the people using all forms of 6 functional appliances. But non-compliant therapy, I would definitely put Forsus as one of the major choices. There's a lot of appliances have come out. If you look at the literature, at least about 25 to 30 appliances are there. But many have fallen on the wayside. They've remained academic curiosities. But appliances like the Forsus, the Jasper jumper, even the original version of Herbs with its sleep device still hold good even today. Correct me if I am wrong, Dr. Sabnuk. These have been like, the workhorses of plaster correction. I think Dr. Sabnuk gave an excellent presentation on the nuances of using the Forsus appliance, and all clinicians would be benefited by it. I personally congratulate him. I congratulate all the viewers who have come today, and I'm sure they have been richly benefited. I thank the co-panelist, Dr. Pradeep Raghav, for his observation, and all of us in turn should thank our guru, Dr. D.N. Kapoor, who brought us together on this platform. Thank you, Kapoor, sir. You have been doing a very commendable job. Please keep the flag high. Thank you very much. Thank you, Dr. Preeti. Thank you, Dr. Sabnuk. Thank you, Dr. Pradeep. Thank you, everyone.
Thank you so much, sir, for your kind words and for accepting our invitation to be the chief panelist. Thank you so much, sir. Thank you. I would like to invite our dynamic dean, Dr. Gurudat Naik, sir, to extend the vote of thanks.
On behalf of Mansarovar Dental College and International College of Dentists, Central Zone Section 6, I would like to extend my vote of thanks to our eminent speaker, Dr. Professor Ramesh Sablok, sir, for this amazing lecture and sharing his knowledge among us. Professor Dr. R.P. Gupta, sir, President ICD Section 6, our chief panelist, Professor Dr. Jyotinder Kumar, sir, Diplomat, Indian Board of Orthodontists, our panelist, Dr. Pradeep Raghav, sir, Professor and Head, Department of Orthodontics and Dentofacial Orthopedics, Subharti Dental College, Meerut, Uttar Pradesh, Padma Shri Professor Dr. Mahesh Verma, sir, Vice Chancellor, Indraprastha University, Delhi, and Chairman ICD Section 6, Professor Dr. D.N. Kapoor, sir, Master Fellow, ICD, Regent, Central Zone, ICD, Section 6, and Organizing Chairman, who has been very supportive and instrumental for conducting this webinar. Dr. V.S. Kohli, sir, Deputy Regent, Central Zone, ICD, Section 6. I would also like to extend my wholehearted gratefulness to Honorable Mrs. Manjula Tiwari, ma'am, Chancellor, Mansarovar Global University, Professor Dr. Arun Kumar Pandey, sir, Vice Chancellor, Mansarovar Global University, Mr. Gaurav Tiwari, sir, Pro Chancellor, Mansarovar Global University, and CD, Mansarovar Group of Institutions, for their constant support and encouragement in every initiative taken by us. My thanks also goes to our creative team headed by Dr. Himanshu Pandey for all their technical support. Not but the least, I would like to thank our organizing secretary, Dr. Preeti Bharadwaj, and our entire team, and also all the participants for making this webinar a great success. Thank you, everyone.
Thank you.